Here we go. So speaking about other diuretics, they have different mechanism of action, but the main function is one. We want to get all of the volume outside of the body. So before speaking about that, I want something from you guys. Can you tell me, please, if I increase the amount of excretion of the urine outside of the body, what is going to happen to the blood volume? What happens to the blood volume with the use of diuretic? It will go down. What happens to the afterload? What about the preload? Exactly, it will be down as well. Okay, good. So speaking now about acetozolamide. Acetozolamide, I feel like I saw this one before. Well, carbonic anhydrase inhibitor. Well, this is making some flashbacks. So regarding there is a question here, is the afterload higher or lower? It will be much lower. Low. Why? Because you are decreasing the amount of volume inside of the vessel. So if you decrease the amount of the volume inside of the vessels, the resistance will decrease as well. Yeah? Okay, so let's take a look. So we have the different cells located at inside of our kidney. It's this page I keep telling you about that we will go back to. So you see at the proximal convoluted tubule, we have this long process happening here. Remember, I told you that the hydrogen goes out, it binds to the bicarbonate. And the main idea from this whole process is to do what? Get bicarbonate in the cell, yes? So bicarbonate makes bicarbonic acid, which then divide to the CO2 and the H2O. Basically, I think about it as a Trojan. I hope you know what a Trojan is. With a J, sorry. Trojan horse. You know, a Trojan is basically like, that's a famous story in which like they brought this Trojan with soldier in it, and after it entered the body, it recombined itself and it led to a pathology. That's how I think about the bicarbonate process of reabsorption. So what do I mean by that? Well, basically you cannot reabsorb bicarbonate directly. Instead of reabsorbing it directly, you bind it to hydrogen, make bicarbonic acid, makes a Trojan, which is the CO2 and the H2O, which will enter the cell and then remake bicarbonate, which will be reabsorbed. Okay, good. So if I'm using carbonic anhydrase inhibitor, can I reabsorb the bicarbonate anymore? Can I reabsorb the bicarbonate if I'm using carbonic anhydrase inhibitor? Yes, I cannot. It's impossible to reabsorb. Why? Because if it's inhibited, I'm not making these substances. If I'm not making these substances, I will not be able to get bicarbonate back in. So what will happen to the bicarbonate? Where it will go? Yes, it will go basically to the urine and to the lumen and then to the urine. So if you are losing a lot of bicarb, you are losing bicarbonate. Will you get acidosis or alkalosis? Acidosis. Okay. So the next thing is the carbonic anhydrase inhibitor, and they go something like this. They inhibit the carbonic anhydrase, which is an enzyme in the proximal tubule, which lead to self-limited sodium bicarb diuresis. Basically, the bicarb is going inside of your urine and some sodium with it. And can decrease total body bicarb stores, which alkalinize the urine. So the urine will be alkaline, but the body will become much more acidic. You are like, well, I'm getting it that you are losing bicarb, but it was written sodium bicarb. Why it's not only bicarb? Notice here, guys, there's a sodium going into this pump. If this process is not functioning, you will have less CO2 and H2O inside of the cell. If you have less of these, you will have less of these. You will have less bicarbonate going into the body and less H. If you have less H, will this pump be working or not? Will the pump be working? No, it will not be working. It will be unable to work. So if it's not working, will you get sodium in the lumen or in the cell? In the lumen. Yes, exactly. It will go in the lumen. And that will lead to sodium and bicarbonate release into the urine. Okay? So let's take a look here. So carbonic anhydrase inhibitor causes self-limited sodium bicarbonate diuresis and a decreased total body bicarb stores. Okay? So, and it alkalinizes your urine. We use it for multiple disease, including glaucoma. Why glaucoma? Because it decreases your intraocular pressure. So, in case of a glaucoma, it decreases your intraocular pressure. And this is not the only thing we use it at. We can use it at other pathologies as well. Come on. Okay, it's not working. So other than glaucoma, we can use it in other pathologies. For example, we can use it in case of metabolic alkalosis. You are like, what? Why? Well, using acetozolamide, we said that it leads to what? Which form of acid-base disbalance does acetozolamide leads to? Why glaucoma? Good question. So glaucoma, we said that the main problem in a glaucoma is an increased intraocular pressure. Yes? Why do we have in a glaucoma increased intraocular pressure? Why glaucoma? Can you repeat? Urine alkali? Yes. Let's start just with the glaucoma first of all, and then we'll go to the next topic. So glaucoma is basically increased intraocular pressure. This increased intraocular pressure damages the optic nerve. When that happens, we call it a glaucoma. Okay? So the pressure is high. Why it's high? Multiple reasons. One of them can be due to increased volume. So it's because you have a lot of intraocular fluid. So if you reduce that intraocular fluid, what will happen to the pressure inside of the eye? It becomes much lower. Yeah? When it becomes much lower, the pressure inside of the eye, because of the diuresis, the pressure on the optic nerve will reduce. That will lead to reduction of a glaucoma. This is the first thing, but this is not the only thing why carbonic anhydrase are used. This is the first one. But carbonic anhydrase themselves, they have one additional function regarding the glaucoma. A function that I hope it's here. If it's not here, it will be in neurology. 1 second. Oh yeah, so it will be in neurology, I guess. Yep, here it is. So yeah, see, the second function in which we use someone sent the picture. Oh, thank you so much for the picture. So the next thing for glaucoma therapy, your main goal is to decrease intraocular pressure. Yes, by decreasing the aqueous humorous, which is the fluid inside of your eye. How can you reduce that fluid? By using acetozolamide. How does acetozolamide work? It works by decreasing the aqueous humorous synthesis via the inhibition of carbonic anhydrase. So basically this aqueous humorous inside of the eye is made in an area called the ciliary body. Okay? So that ciliary body inside of your eye is basically a portion of your eye that makes it has a form of epithelium that leads to the formation of the aqueous humorous. It has a carbonic anhydrase receptor on it, and if you inhibit them, you have less synthesis. So acetozolamide has two mechanisms in which it decreases glaucoma. Okay? Good. So the next thing, renal, going back here. Okay. So the next thing is altitude sickness. During altitude sickness, are you having tachypnea or bradypnea? Are you breathing quick or slow? You are hyperventilating. If you are hyperventilating, what you are exhaling a lot? What are you getting outside of your body? Yes, CO2 outside of the body. And that lead to what? Alkalosis. Is it respiratory or metabolic? Respiratory, exactly. Respiratory alkalosis. So you want to fix this respiratory alkalosis using the kidney by using acetozolamide. Acetozolamide leads to the loss of bicarbonate. So it leads to which acid-base disbalance? Yes, exactly. It leads to metabolic acidosis. Metabolic acidosis. Yep. So that goes against the altitude sickness, which lead to respiratory alkalosis, and thus we have the patient cure. Also, the last thing is called idiopathic intracranial hypertension, which is basically also called pseudotumor cerebri. Let me tell you a couple of points about this disease. In this disease, basically the patient, why we call it first of all idiopathic, because we have no idea what caused it, but we have some risk factors, okay? It's also used to be called pseudotumor cerebri. This pseudotumor cerebri is most commonly in an obese patient. Also, it's common in ladies who are obese or have polycystic ovarian syndrome, or also patient taking retinoic acid, okay? Which is vitamin A. So all of these can increase the pressure inside of your cranium, which lead to idiopathic intracranial hypertension. You must know why we call it a pseudotumor cerebri. Guys, in case of a brain tumor, when does the headache occur? Is it in the morning or in the evening? It occurs in the morning. Good. Early in the morning that it wakes them up. Okay? It wakes them up from the sleep. And when this idiopathic intracranial hypertension, also called pseudotumor cerebri, they have the exact same symptoms. You do an MRI on their brain and you see nothing. So it's idiopathic intracranial hypertension. You might see dilated ventriculi though. Okay, so the adverse effect is proximal renal tubular acidosis, which is a type 2 RTA due to dysfunction of the basically PCT. Yes? Also, these patients can develop paresthesia because of loss of some electrolytes, NH3 toxicity, also because of poor reabsorption, sulfa allergy as well. Keep in mind that all diuretics are sulfa drug except one, okay? And also they have hypokalemia as well because you are losing it in the urine. It promotes to calcium phosphate stone formation. Why? Remember that we spoke about a couple of stones that increase the risk of developing basically stones. For example, when the patient has high pH of the urine. If someone has a high pH of the urine, which type of stone is he at risk at except calcium stones? Okay, magnesium, ammonium, phosphate stones. That is correct. Okay, so it can lead to magnesium, ammonium, phosphate stones. Can you tell me, please, what else it can? These stones, what they are big, small? How do they look like? Yes, they are really, really big. They are also called as Staghorn stones. Yeah, we call them as Staghorn stones. Good. So, so Why hypokalemia? Good question. So the reason that you have hypokalemia is here. It's in the same picture. Where are you? Just a second. Yes. Okay, so in this case, in this pathology, are we having more sodium or less sodium inside of the kidney? I mean, yeah, you will have less reabsorption, correct? Less reabsorption. If you have less reabsorption of the sodium, it will keep going until it reaches this area. Well, that will lead to movement of more, sodium inside of the cell at this area. What that will kick from your body because of the creation of the negative charge. Done. Yes. Because of the creation of the negative charge inside of the tubule, it will kick the potassium outside. It's bad actually that you have to correlate them together, these different tubules, and follow them one by one. Speaking about the Staghorn stone, can it go away on its own or it needs surgery? Surgery, no joke about this one. No drug will work. Okay. So here we have, it promotes calcium phosphate stones formation, which is insoluble at high pH. We also spoke about the MAP. Okay, and its function at the BCT. Good. So yeah, they are too big, ridiculously big. Okay, so speaking about the loop diuretic, we have furosemide, butenamide, and torsemide. Finish with amide. But here is the thing. Before I continue, I want you to know one thing. This one, and all of the other ones are all sulfa drug except one. This guy. Ethacrenic acid is the only drug that is a diuretic and it's not a sulfa drug that we will see today. So furosemide and butenamide and all of these guys, they are loop diuretics. Remember that the loop diuretics work at the thick ascending loop of Henle, this area, thick ascending loop of Henle. So they inhibit the co-transporter. So this co-transporter co-transport what? Sodium potassium 2 chloride pump, which is here. So you can see here, sodium potassium 2 chloride bump, and it reabsorb all of these substances. So loop diuretic will lead to its inhibition, yes? Okay. Good. So that will lead to its inhibition. As you can see, sulfonamide loop diuretic inhibit the co-transporter system, the sodium potassium 2 chloride of the thick ascending limb of Henle. It abolishes the hypertonicity of the medulla, preventing concentration of the urine. So basically, if we speak about the suction of these substances, if we use loop diuretic, will you have more or less reabsorption of these substances? Obviously less. Okay, so if you reabsorb less of these substances, you basically are having hypo or hyperkalemia. Hypokalemia, good. What about the chloride, high or low? Chloride and sodium? All low. All of them will be low. So the tonicity of the kidney will go up or down? I mean the interstitium of the kidney, yes, it will be down. Okay, so one more function that is related with the loop diuretics is they actually increase the production of prostaglandins. This is a different mechanism, but this is actually cool. Well, they are smart. They are like, we need to increase the diuresis. How can we increase the diuresis? Well, we are like, okay, we are doing it by inhibiting this channel. So they were like, can we do two at once? They were like, yeah, what are you thinking about? He was like, dilate the afferent arteriole using prostaglandins. So the loop enhance prostaglandin synthesis. The more prostaglandins you will have, what will happen to the afferent arteriole? Vasodilate. So what will happen to the perfusion of the kidney? It will be up. So what will happen to the amount of blood reaching the kidney and the amount of, yes. So basically there will be more fluid delivered to the kidney, yes? More fluid to the kidney, that will lead to more diuresis or less diuresis. Yes, more diuresis, more urine, exactly. Which is that what exactly what we want. Well, since they work at the prostaglandins, they only work at the prostaglandins. They do not work at the angiotensin 2. So you tell me, will it be only afferent or afferent and efferent? They only work at the prostaglandins. Only afferent, yes. So if this one is, okay, this is actually a good note. If this one is, well, bringing too much blood, and this is still the same, what will happen to the GFR? Up. Filtration fraction? Up. When filtration fraction is up, amount of urine? Excellent. Good. So it's inhibited by NSAIDs. Remember, NSAIDs inhibit the prostaglandin synthesis. They also mention here that it leads to increased calcium excretion. The question is why? Well, why it leads to less calcium excretion? The answer comes here. Well, let's go back and speak a little bit about this pump. Normally, let's speak about normal before speaking about loop diuretic. Normally, we had sodium potassium 2 chloride absorbed inside of the cell. So after they were absorbed, what happened to the charge of the lumen? What happened to the charge of the lumen? I mean, what happened to the electrical potential of the lumen? It becomes more negative. You are sucking more positive inside, so it becomes more negative. So the potassium need to recompensate for that by getting the potassium outside to the positive channel, okay? And when it gets out, it makes it more positive. If you have a lot of positive, there is no place for magnesium and calcium to stay, so they have to run away. So they go inside of your body. But if this pump is not working, will the calcium and magnesium be absorbed or go to the urine? Urine. They will go to the urine. So you will have hypomagnesemia and you will also have hypocalcemia. Okay, so let's take a look here. They mention that you will have a loss of calcium. So Edematous is, oh yeah, they love this thing. Furosemide is always this drug that always nephrologist and cardiologist fight over. The cardiologist always want to start it and the nephrologist always want to stop it. Okay? So it's used in edematous status and it works amazingly, I have to say. Like you give it to the patient, they cannot breathe, and then like after like 2 days, they are totally normal. So we use it in cases of heart failure, cirrhosis, also nephrotic syndrome, basically anything that leads to third spacing. Do you know what third spacing mean? Third spacing is basically an edematous. Third spacing is the movement of the fluid into basically another cavity. Well, for example, leading to the edema. So speaking about that, we have, yes, Yes, all of these edematous state can be improved if we do what? If we increase the diuresis. Okay? Why not nephritis, only nephrotic syndrome? Well, you tell me, when do we have more protein excretion? Why do we have when we have more protein excretion? Is it in nephritic or in nephrotic? Exactly, it's in nephrotic. So since it's in nephrotic, when will you be higher at risk of edema? Is it nephritic or nephrotic? Nephrotic, yes. Thus, when will furosemide be much better, in nephritic or nephrotic? Furosemide help in edematous states. Exactly, nephrotic. Yep. Okay, guys, just 1 minute. I just need to grab my charger and come back. 1 minute exactly. Recording thing. And yes, good. So moving on, we now need to speak about the hypertension. So we use this diuretic for hypertension as well. Why would you use a lube for hypertension? Because it increases the amount of the sodium inside of your urine, which decreases the volume inside of the body. Decreasing the volume inside of the body leads to what? Less volume inside of the body basically lead to less hypertension. We use it in cases of hypercalcemia. Why? Because it trashes the calcium. Yes, it trashes the calcium. It has some side effects you must know about. It can lead to ototoxicity. Can someone tell me which antibiotic lead to ototoxicity? Antibiotic leading to ototoxicity. Aminoglycosides, exactly. Streptomycin, good. Okay, good. So let's move back. Ototoxicity, hypokalemia as well. Well, let me give you this little trick. All diuretics lead to hypokalemia except one. Do you know which one? Which diuretic does not lead to hypokalemia? The potassium sparing diuretic. It makes sense, but they are potassium sparing. They do not lead to hypokalemia. Good. Okay, so also hypomagnesemia, we saw that aboard, like when we had the trashing of the magnesium and the calcium together. Dehydration, obviously. Allergy, why? Sulfa drug. Again, sulfa drug? Yes, I told you, all of them are sulfa drug except one. And metabolic alkalosis as well. Why? Why metabolic alkalosis? Well, are you losing, what is going to happen to your potassium if you use loop diuretic? Is it going to be high or low? Low. Okay, so if it's low, what is going to happen to hydrogen, his best friend? Low. Yeah. So if both of them are low, are you if your hydrogen is low, are you going to have alkalosis or acidosis? Alkalosis. Good. So okay. And the other thing is nephritis, which is like interstitial nephritis. If you remember, we spoke about this one, and which characteristic cell was in interstitial nephritis, if you remember, and interstitial cast even, about interstitial nephritis. There was one form of cast. I told you that it's highly specific for interstitial nephritis. Come on. Somebody got it? Interstitial nephritis. It was the eosinophil cast. Okay, eosinophil cast. Okay, so let's take a look here. And finally, gout, because they have hyperuricemia. Okay, so this drug is important, ethacrenic acid, because basically it acts exactly like a loop diuretic. So it is a non-sulfonamide inhibitor of the cotransporter system. So it works exactly like loop at the sodium-potassium 2-chloride channel of the thick ascending limb of Henle. And the clinical use is diuresis in patient with diuresis in patient that have, well, basically sulfa allergy. The adverse effects are the exact same as furosemide, but it's more ototoxic. But which side effect will not exist? The allergy. Because what? It's not a sulfa drug. Yes, it's not a sulfa drug. So this is the only one that you need to know that it's not a sulfa drug. The other ones, acetozolamide, loop diuretics, thiazide, they are all considered a sulfa drug, okay? So, yeah, so far we have only one that is not a sulfa drug. So moving on, we have this page, thiazide diuretics. We have hydrochlorothiazide, chlorothalidone, and this one that I keep forgetting personally, metolazone, okay? So this metolazone as well. So the mechanism, they work at the DCT, but here we say early DCT. Why? Because the DCT is two portion, early and distal. Well, the early portion of the DCT, you have basically the thiazide working. What about the distal portion of DCT? It looks exactly like collecting duct. So it has a principal cells, alpha intercalated cells. It looks like a collecting duct. So the mechanism of thiazide diuretic is the inhibition of sodium chloride reabsorption in the early DCT. So if you cannot reabsorb sodium chloride, it will go inside of your urine, which lead to decreased diluting capacity of the nephrons and also will lead to less calcium excretion. Let's think about this for a moment. If we have a lot of sodium chloride in the urine, what will happen to the volume of the urine? What will happen to the amount of the urine? Yeah, more urine, diuresis. Yes, because the sodium will suck more water. Okay, good. So moving on, we have the following. It's written that there is less calcium excretion, which lead the patient to have hypercalcemia. This can be used therapeutically. Why? Look at the clinical use. One of them is this one, osteoporosis. So we can use it in osteoporosis because it leads to hypercalcemia and it prevents the excretion of calcium outside of the body. If you have a prevention of the excretion of the calcium outside of the body, you will have more mineralization of the bone inside of the body, which basically can prevent osteoporosis. Also, it's used for hypertension. This is just a common sense because it decreases your preload, decreases your afterload, and makes your life better. Heart failure, diuresis, less edema. Idiopathic hypercalciuria. Some patient can have a lot of calcium in the urine. Why this is a bad thing? Why it's a bad thing to have a lot of calcium in your urine? So they write like hypercalciuria. Like it's a familial disease basically, in which like the patient have a lot of calcium in the urine. Yes, basically they are at higher risk of developing stones. So if I give him a thiazide, the thiazide will lead to less calcium inside of the urine or more calcium inside of the urine. It will lead to less calcium inside of the urine. So if the patient has less calcium in the urine, that will lead to less risk of forming stones. Yes, and that's what we want. So here they write the patient can use it as well for nephrogenic diabetes insipidus. Now this one gets all of the students tricked. The moment they see this one, they try to understand it for a million years. It does not work. Personally, the first time I saw it, I got flipped myself. But after that, I understood how it worked. So basically, the thiazide, it's a diuretic. So it leads to a state of hypovolemia. But where is this state of hypovolemia? Is it in the proximal kidney or at the distal convoluted tubule? It is at the distal convoluted tubule. Yeah, let me just trying to copy this picture because this is, yep, oh, okay, this is much better. At the distal convoluted tubule, yes. So it leads, lead to less distal tubular sodium reabsorption, which increases your urinary excretion. You have more urinary excretion. So your extracellular volume goes down big time. If your extracellular volume goes down, which system, your kidney will be hypoperfused. So which system will be activated? RAS. And that will lead to proximal sodium and water reabsorption because of the affection of the angiotensin II. So there will be less distal delivery of sodium and water, which decrease the urine output. Again, let's apply this one more time. A guy was nominated for Nobel Prize for this. So thiazide lead to what? Decrease distal tubular sodium reabsorption. Yes? So you have more sodium inside of the urine. More sodium inside of the urine will suck more what? In which system we will study? Endocrinology. So more distal tubular sodium reabsorption, so will be low. Thus, you will have more sodium in the urine. More sodium in the urine will lead to more water in the urine. That will lead to reduction of the extracellular volume, and that will lead to your proximal tubule be like, there is less volume in this body. Let me reabsorb more sodium. So he will reabsorb more sodium and water proximally. So there will be less distal delivery of sodium and water, which lead to less urine output in patient who has diabetes insipidus, which basically help him. Yes? We will come back to this picture when we do endocrinology. Okay. So the next thing is adverse effect. For example, the patients can have hypokalemic metabolic alkalosis. Remember, actually don't remember, all of them has metabolic alkalosis, all of them have hypokalemia except one, potassium sparing diuretic. Okay? So also they can lead to hyponatremia obviously and hypochloremia obviously, but there is 3 symptoms that you must master. Okay? They are the hypergluc. So hyperglycemia, hyperlipidemia, hyperuricemia, hypercalcemia. Look guys, this is actually quite interesting because thiazide is considered one of the first lines as for the treatment of hypertension. People who are hypertensive tend to be also, well, obese as well. So it's a bad idea to give, when you want to give a thiazide to this patient, you need to keep in mind the pros and the cons of giving them the thiazide. Because the thiazide can lead to increased blood sugar, increased lipid, and increased hyperuricemia. So it's contraindicated in which disease because of the hyperuricemia? Can someone tell me? Which disease? Hyperuricemia, I said. Hyperuricemia is increased uric acid. Yeah? Gout. Yes, gout. Good. So, yeah, that's in case of thiazide. Thiazide are not that bad. Next one, yeah, again, sulfa allergy. So the next one is potassium sparing diuretic. Speaking about the potassium sparing diuretic, we have spironolactone, eplerenone, amiloride, and trimterone. To make it simple for you guys, we need to go to that picture that I told you. We will speak about it a million times. Even when we do other system, we'll go back to it. So you can see the aldosterone function at the basolateral membrane near the blood side, while we have the ENaC channel located near the urine side. So if we speak about these drugs that ends with 1, like spironolactone and eplerenone, remember aldosterone also ends with 1. So they all act at the aldosterone receptors. They are direct aldosterone receptor blocker. While the other 2, which are amiloride and trimterone, they work at the ENaC channel, which is located near the urine side. Okay? So moving downward. Yes. So you can see here, they write spironolactone, eplerenone, amiloride, and trimterone. Mechanism. So spironolactone and eplerenone are competitive aldosterone receptor antagonists in the cortical collecting tubule, while trimterone and amiloride blocks the sodium channels at the same part of the tubules. So yeah, basically we just said trimterone and amiloride blocks the which channel? The ENaC channel, while spironolactone and eplerenone, the one that ends with 1, work directly at the aldosterone receptor. Just I advise you to master this beige. I told you, print it, put it somewhere. So, spironolactone eplerenone at the aldosterone receptor, amiloride and the triamterone at the ENaC channel. Okay, next. So the next thing you must know, it goes something like this. So clinical use, hyperaldosteronism. Why? Because these are basically what? Aldosterone receptor antagonists. So they will reduce the hyperaldosteronism function. So also potassium depletion. Why? Because they are potassium sparing. Okay? In case of heart failure, because they reduce the function of aldosterone. Guys, does anybody remember the substances that lead to remodeling of the heart? Which substances lead to remodel? No, not to prevent, but leads to remodeling of the heart. Yes, remodeling of the heart means change of the structure of the heart that will become irreversible and constant damage to the heart. If you forgot about these ones, they are angiotensin 2, aldosterone, and catecholamines. Exactly. Yep. Wow, somebody wrote it better than me. Okay, so the next one is hepatic ascites. In case of hepatic ascites, we also give spironolactone, potassium sparing diuretics. And also in case of hepatic ascites, we have this cocktail actually. We give 2 drugs, not 1. We give furosemide and we give spironolactone. When they work with each other, they mediate the patient electrolyte, and in the same time, they lead to diuresis, which decrease the ascites. Nephrogenic DI, we use amiloride. We are like, why? Because it blocks which channel, amiloride? Does it block the aldosterone channel or the ENaC channel? The ENaC channel, exactly. Okay, also anti-androgen, spironolactone acts as an anti-androgen. So adverse effect, hyperkalemia, potassium sparing diuretic, which can lead to arrhythmia. Speaking of the devil, let's take a look at hyperkalemia induced arrhythmia. Well, remember, in case of hypokalemia, what happened to the T wave? Hypokalemia, what happened to the T wave? In case of hypokalemia, the T wave became flat. Now, in case of hyperkalemia, what will happen to the T wave? Become high, exactly. So it will become a prominent T wave. So if that persists, you can have this sine rhythm in which the T wave will be ridiculously high, the read will not be even readable, okay? So it can precipitate to arrhythmia. Good. So also endocrine effect with the spironolactone, as we said, it's an anti-androgen. So it can lead to gynecomastia and anti-androgen effects. So let's speak about diuretics, electrolyte changes. So they can have some change in the urine NaCl. So increase urine NaCl with all diuretics. Okay? Concentration vary based on the potency of diuretic effect. Let me give you the following diuretic. You will tell me which one of them is the strongest. Loop diuretic, thiazide, potassium sparing diuretic. Which one is the strongest? Okay, loop is the strongest. What is next? So loop is the strongest. What is the next strong? Thiazide. Okay, what is the weakest? Potassium sparing. Okay, so that's by the strength. Okay, let's take a look. So they write also serum NaCl may decrease as a result. Yeah, because you are throwing it in the urine during using of diuresis. Diuretics, sorry. Urine potassium, it increased, especially with loop and thiazide, excluding potassium sparing diuretic. I told you, all of the diuretics lead to basically increased urine potassium, except the potassium sparing diuretic because it spares the potassium. The next thing is the blood pH. Blood pH will be decreased sometimes, for example, in case of using of carbonic anhydrase inhibitor. Why? We described how in that disease we had decrease in the bicarb reabsorption indirectly, and in case of potassium sparing diuretic. Why? Because in case of aldosterone blockage, that will prevent the secretion of both potassium, and potassium love whom? Hydrogen. So you will have, well, basically it will prevent their secretion, and thus there will be acidemia, and that will decrease the pH. Yes? Additionally, hyperkalemia can lead to potassium entering the cell via the hydrogen potassium exchanger in exchange for hydrogen exiting the cell. So the more potassium you have, more potassium will enter the cell. As a response from the cell, it will get more hydrogen outside of the cell. What I'm trying to tell you here that inside of your cells, if you have a lot of potassium in the periphery, potassium will go inside, and instead of it, hydrogen will go outside. When the hydrogen goes outside, that will lead to acidosis. Okay? The next thing is the alkalemia, which is increased pH. Loop diuretic and thiazide causes alkalemia through several mechanisms. The first one is volume contraction. In case of volume contraction, you will have activation of the RAS system, which lead to more angiotensin II. More angiotensin II lead to sodium hydrogen exchanger activation, which was located at the BCT, and thus you will have more bicarbonate reabsorption, which lead to contraction alkalosis. Okay, potassium loss leads to potassium exiting all cells via these channels again. So in exchange for hydrogen entering it. So the more you lose potassium, the more what will happen? Potassium exiting the cells in exchange to hydrogen. So hydrogen will enter the cells, which lead to alkalemia. If hydrogen enter the cells, you will have less hydrogen in your plasma, which lead to alkalemia. So in low potassium state, hydrogen rather than potassium is exchanged for sodium in the cortical collecting tubule. So one more time, in case of low potassium state, if you have low potassium, hydrogen rather than potassium is exchanged for sodium. That's cool. In the cortical collecting tubule. They are so friendly with each other, the potassium and the hydrogen, that you can use the hydrogen instead of the potassium in the cortical collecting tubule, which can precipitate to alkalosis and paradoxical aciduria. Okay, the last thing, the urine calcium, that will lead to more, it will be higher with loop diuretics because it decreases the paracellular calcium reabsorption. Thus, you will have hypokalemia in the blood, but in the urine, the calcium will be really high. Finally, with thiazide, there will be an enhanced calcium reabsorption. So if you use thiazide, you will have more reabsorption of calcium. Thus, we used it in which condition? Which condition do we use thiazide? Because it reabsorbs the calcium. Which disease did we use the thiazide? Because it was really good in reabsorbing the calcium. Yes, it was the osteoporosis. Exactly, it was the osteoporosis. Okay, guys, can you tell me, please, would you like to dedicate to start a new system next time, or would you like the next class to be an overview of the whole thing? Next class, review the whole system for 3 hours. We will do a crash course. We'll cover the system really quick, and we can do that's choice number 1, review the whole system. Choice number 2, review in one part and start new. I like that, start new. And the last one, start new. Okay, everybody. So for me, that's it for today. I don't want to speak about these drugs because they are super high yield, and I don't want to that all of us are tired by this time.